How many of you are melanoma survivors? Okay, how many of you are melanoma caregivers? How many of you are none of the above? How many of you know somebody that's had melanoma? Yeah, or yourself? Okay, thank you. I just don't know who I'm talking to. So my talk today is basically, this is most people's idea of what a pathologist does. And it's actually pretty close, although we're not investigating crime scenes or criminals, and we're certainly not as glamorous as these people. We really are drilling down deep into your specimen to try to get the best answers to guide the surgeons for treatment and to give you the most accurate idea of your prognosis. So in this brief talk, I'm going to give you just a brief background on the impact of melanoma, what happens when your physician suspects you have one, how we analyze the melanoma, and just talk a little bit about some newer techniques that are coming down the pipeline. Skin cancer affects 1 in 5 people, and there are going to be about 5 million new cases of skin cancer diagnosed in the United States every year. And the vast majority of these are not melanoma. They are called the non-melanoma skin cancer. So up on the top left is the squamous cancer, and then the far more numerous basal cancer. And we kind of group these into non-melanoma skin cancer, or the more politically correct way, I guess, to call it now is keratinocyte cancer. Those arise from the skin surface itself. Melanoma is a small percentage. It's only about 3% of all the cases of skin cancer, and there's going to be about 130,000 new cases in the U.S. Last year was estimated. However, deaths from melanoma are disproportionate and cause about 80% of the deaths from skin cancer, and almost 10,000 people a year die from melanoma. And as we have all heard, the incidence of melanoma is rising. And this, I'm sure you can't see this, but it's hard to graphically depict it. What this slide shows is the rising incidence, the incidence of melanoma in different age groups. So on the x-axis, we have the different ages broken down 5 years at a time. So one take-home message is the incidence is very high and it continues to increase as you get older. Well, thank you. Now I just have to figure out how to use it. Continues to increase as you get older. But another is that the bars, there's 4 bars here, and the bars on the left show the incidence of melanoma between 85 and 87, and the sets of bars on the right contrast the incidence in the late 2000s, 2007 to 9. So you can see for each age group the huge jump in melanoma incidence over those 2 decades. So what is your personal risk of developing melanoma? An average person born today has a 1 in 33 chance of getting some form of melanoma. Some of those are non-invasive and are cured by simple excision, and others are the invasive type that we're here to talk more about today. And a 1 in 63 chance of the invasive or deadly form. And so early diagnosis is the key to better survival, because if your melanoma is diagnosed early before it has spread, you have between a 75% and 99% chance of living for 5 years. If your melanoma has spread to lymph nodes when you're diagnosed, you have about a 60% chance of living 5 years. And if it is spread throughout the bloodstream, that falls to between 10 and 15%. Although our wonderful oncologists are doing a lot to improve that number. But the good news is about 83% of melanomas are diagnosed in that localized stage. So I know that you've all seen the ABCDs of melanoma, and I'm sure you're going to see it again today. My point is to tell you that not all melanoma does follow the ABCDEs, and these are some pictures of kind of nondescript looking bumps that are in fact melanoma. So when you're, as a dermatologist, you have to have a very high index of suspicion for lesions, and dermatologists evaluate far more than the A, B, C, D, E's. And what that equates to is that we get, knowing that making an early diagnosis requires this high index of suspicion, a lot of skin biopsies. And another kind of interesting figure is how good are doctors at recognizing melanoma. Well, the more they see, the more they know. So general practitioners, if 100 patients walk in the door with a melanoma, they're only going to say that's melanoma 30 to 50% of the time. And that rises if you're in training as a dermatologist, and it's the best if you're an experienced dermatologist. But it's not always 100%. So if you have a suspicious lesion, how is it biopsied? There's 3 choices, and none of them are wrong. The point is to get the lesion off and send it to the pathologist for analysis. The choice of procedure is based on the skill of your practitioner, the time they have in the office, and the size of your lesion. The most common method is the shave biopsy, where a little scalpel is used to take off the lesion, leaving a small divot in the skin. A punch biopsy can go a little bit deeper. This picture shows the skin surface, and it shows how the punch can go down into the fat, and that's that small round cookie cutter. Those aren't very big, so they're not good for lesions that are kind of broad. And really the one that all the textbooks favor is the excisional biopsy, where actually the whole lesion is taken out. But that's hardly ever done because it takes time. You have to set up the room, and you have to make sure the patient's not on anticoagulants, etc. So honestly, about 65% of our lesions come in with a diagnosis of melanoma have been shaved. So once it's shaved, it goes this little bottle of the specimen in the room, and then you send it to your doctor, and then what do they say? Let's send it to the pathologist and see what they say. And then the clock starts ticking, and you're waiting for your report. And I know all of you have had that, or your patients have had that experience. So what goes on behind that door in pathology? Actually, quite a bit. There's quite an involved workflow to get the specimen to me. So just briefly, what happens to it is, first of all, we have a pathology assistant that checks it, measures it, makes sure that all the specimen labeling is accurate. They put it into a little plastic cassette here, and that cassette goes into a machine that's about the size of a minivan called a processor, and it sits there overnight, and then it comes out as a piece of tissue covered with wax or infiltrated with wax. And then a histotechnologist puts that specimen in a larger block of wax and cuts it with a knife that's like made of diamond. One of those knife blades costs like $15,000, and they cut it into pieces that are 3 micrometers thick. Those sections are stained on a stainer, and so we get a slide of your specimen, and I read it. And once we read it, we render our pathology interpretation. And this is what a sample pathology report looks like. And when you get your report, the first thing that you should look at is the name of the doctor. And for skin specimens, especially pigmented lesions, the best person to read it is a board-certified dermatopathologist. So that's a pathologist who's had extra training in skin pathology. Now, what is the essential information on that report that I'm going to produce? First of all, your clinician that does the biopsy has a responsibility. For me to make the best interpretation, they need to say, give me certain elements, such as, has the lesion changed? How big is it? Are they taking just a piece of it or the whole thing? What does it look like? Has it been biopsied or traumatized before? Another thing we get from our kids with melanoma, has it been treated by a topical treatment before? Because things like compound W and trying to freeze it off can change the way it looks. I need to know all that. And then what I have to give the clinician back is hopefully the correct diagnosis. as well as information to guide the search and treatment and prognostic information. So, first of all, in making the correct diagnosis, similar to the clinical ABCDEs, as a pathologist under the microscope, there are pathology ABCDEs, and these are some pictures of actual melanomas that have changes under the microscope very similar that relate to the changes that are seen in melanoma on your skin. And I'm not going to try to teach them to you, but just to show you that we analyze a number of features that distinguish your pigmented lesion as a melanoma and not a harmless lesion such as a mole. This diagnosis is not always straightforward. Not all melanomas violate the ABCDEs, so you might hear your doctor saying, well, they had to do a number of special stains and the report is going to take a long time. That happens a lot here. Every patient is special, but some tumors are even more special than others. So sometimes we have to do stains that look at different expression of different antigens by tumors, and these are some of the common stains that we use. The S100, the melanine, the HMB45. Sometimes even special stains aren't enough, and there are some newer techniques that can delve into the DNA of your tumor to try to tell us whether it's benign or malignant. And these are techniques that are performed at labs outside of Moffitt. They're very specialized. They're not done in huge numbers, so they're best done in a specialty lab. And one of the ones that's most commonly done is fluorescence in situ hybridization. These are done on lesions where the pathologist is having difficulty saying whether your lesion is benign or melanoma. And that detects extra copies of certain genes. It costs about $400. The insurance pays for it. It takes about a week to do. And even more rare is something called comparative genomic hybridization, where it actually tells you if there's extra chromosomes or loss of chromosomes. And that's done very limited availability. It's much more expensive. That's done a lot in kids with difficult lesions. So once I get the correct diagnosis, what is my next step? Well, that's to provide information on my report to guide the surgeon in treatment. So I'll show you another pathology report that I'm sure nobody can read except the people in the front row. But you'll see up here, the word melanoma is actually, the smallest part of the report, and then there's this huge list of key pathologic findings. Those are features that I can see under the microscope that characterize your melanoma, and every melanoma is different. And the three that are used by the surgeon to determine the correct treatment are those that are involved in the staging of the melanoma. And they are the thickness of the tumor, whether or not it's ulcerated, and how many cells are dividing in it, or the mitotic rate. And I'll show you exactly what these look like. First of all, the thickness was discovered by Alexander Breslow in the 70s, and he put a ruler inside the eyepiece of his microscope and realized that how deeply the tumor had penetrated into the layers of the skin was directly related to the prognosis. And here's how we measure it. Here's a piece of skin. These cells are all melanoma. You can see some brown pigment there. And this is the tumor thickness, how deeply it has invaded into the skin. Ulceration is another feature. Tumors that are ulcerated. An ulcer means, you probably all know what it looks like clinically. You've got a loss of your skin covering and the lesion is oozing. And not only melanomas ulcerate, but other tumors do too. Here's a non-ulcerated tumor with intact skin. Here's an ulcerated tumor where the skin surface has been lost. And when a tumor ulcerates, that implies that it's either growing rapidly or there's some bad growth factors. Tumors that are ulcerated behave much worse than those that are not ulcerated. Mitotic rate is actually, we can look into the tumor on a high power, look at the individual cells, and I've got little arrows pointing here to the cells that are dividing. And we count how many of those are present and that directly also relates to the prognosis. We put all of these together, the thickness, the ulceration, and the mitotic rate, to come up with a stage called the T stage, tumor stage. And that number is what's used by your surgeon to just dictate what treatment you're going to have. And I'm sure you're going to hear about more of that when Dr. Symposium fly over all that information. So just remember that what I give you for T stage is how the surgeon knows what to do for you. One thing I will note that a lot of patients have a misconception on is that the T stage is one part of the overall staging system for cancer, which is from 1 to 4. And I think everybody knows stage 4 tumor is a bad thing. Well, there's T's. The T's have different numbers too, 0, 1, 2, 3, 4. A T4 tumor doesn't equate to a stage 4 melanoma. So a lot of patients come in worried that they're dying, when in fact all they have is a T4 melanoma, but that's not the same as a stage 4. And then prognostic information. This is the one area that we are still doing active research on. And I'll just give you an illustration of 2 cases that tell you how far we have to go with analyzing tumors to tell you what the prognosis is. Typical story here, 42-year-old male, melanoma 1.1 millimeters in depth. He undergoes the standard treatment, which is wide excision and removal of his sentinel node. They're negative, and he's alive 10 years after diagnosis. Next day, you can see this sort of the same kind of patient, 20-year-old male, 1.1 millimeters in depth, undergoes the same surgery, but he has tumor in one of his lymph nodes, and within 6 months develops lung metastasis. Both of these patients had the same T stage at diagnosis, but one behaved worse than the other. And as a pathologist, that's an area of active research, is figuring out what more besides the Breslow depth, the ulceration, and the mitotic rate is going to determine the patients that are going to do badly. And there's very little information that we can accurately use in this realm. So this is an area of active research. It's one of the reasons that I give this long laundry list of other features that I can see under the microscope. All of these have been found by one or more researchers who have some relevance to prognosis, but not as strong as tumor depth, ulceration, and mitotic rate. But we are gathering this information on the 1,500 new melanoma patients we see per year, and maybe in long-term studies with great numbers of patients, one of them will come out as being accurate. And that's basically what I just said. There's one test that has been marketed recently for prognosis by the Castle Corporation. We don't use that here. We consider it still yet to be proven, but you may hear about it from your dermatologist. And this is a test that's done on your tumor after it's removed, and sections of it are sent off to the Castle labs, and they have a signature that they believe predicts patients that are more likely to develop distant spread or have poorer survival. Like I said, we don't use that, but I think tests like this, similar to the ones that are being used in breast cancer, are an area of active research and marketing, and hopefully we will get one that we can use in addition to our staging and our sentinel node removal. But there's still many, many pieces of the puzzle that are left to be filled in. These are some of the areas of the puzzle that are being actively researched, like markers of the primary tumor to predict prognosis, or genetic features of the tumor that can predict response to treatment, and you're going to hear about these later from our oncologists. So in summary, I hope I taught you a little bit about all of these objectives, and I thank you very much for your attention.